Hello, everyone, and welcome to our 2025 PKD Summit. My name is Michelle Lynn Goodfellow, and I'm the Communications and Engagement Manager for the PKD Foundation of Canada, which is the only national organization solely dedicated to fighting PKD through research, advocacy and awareness, and education and support. This session is a presentation by Dr. Tiina Podymow and Dr. Ahsan Alam, and they'll be talking about pregnancy when you have PKD. We'll have a live question and answer period at the end of the presentation. And if you'd like to put your questions in the Q&A area or in the chat, we'll try and get to them at that time. This session is being recorded and will be available to view on our YouTube channel in the coming weeks. So I'll now introduce our presenters. Dr. Tiina Podymow graduated from McGill University and completed her medical residency and nephrology fellowship at the University of Ottawa. She continued fellowship training in obstetric nephrology at Cornell University at New York Presbyterian Hospital. She's an associate professor in nephrology at McGill and is a practicing nephrologist at the Royal Victoria Hospital of McGill University Health Centre, with a clinical and research interest in obstetric nephrology. She also runs a first-year McGill Medicine Renal Physiology course and is a past winner of the Douglas G. Kinnear Award for Outstanding Clinician Teacher at the McGill University Health Centre. Dr. Ahsan Alam is an associate professor of medicine and a staff nephrologist at McGill University Health Centre in Montreal. He's also the medical co-director of the MUHC Multi-Organ Transplant and Donation Program. In 2015, he established the MUHC Polycystic Kidney Disease Clinic and co-founded the Quebec PKD Network to enhance PKD knowledge, translation, and research in the province. He's an active member of the Research Institute of MUHC and is actively involved in PKD clinical trials and epidemiologic studies. He was recently awarded the MUHC Department of Medicine's Clinician Impact Award for his contributions to the field of ADPKD, which have had a medical or societal impact through publication, guideline development, and work with policymakers. So welcome, Drs. Podymow and Alam. We're so glad to have you here today. And we are going to start with Dr. Podymow.
Actually, I'm gonna start if that's okay, Michelle.
Oh, sure.
Yeah. Thank you so much, Michelle. And thanks to the PKD Foundation of Canada. It's really a pleasure to speak to this audience and to really hopefully help and promote education around this important topic. And I think this is a very interesting topic. It's an area that certainly as a nephrologist who does PKD, I'm always challenged with, and so I'm very happy to have my colleague Dr. Podymow here to help me with this conversation. So I'm going to start with, just because there, it's unclear sometimes where people are starting and what information they're coming with. I just wanted to highlight some disclosures. So I will be mentioning a medication or treatment that is involved with the PKD, and there are a couple of companies that supply this medication. So it's Canada and Lupin Pharma, and so I just wanted to make that disclosure. But I will start with a bit of an overview of ADPKD for those who might be coming as newer people in this area. And so I think most people know that PKD is the most common genetically inherited disease. This slide says it affects about 1 in 500. The numbers will range 1 in 500 to 1 in 1,000 of the population. But although it's a genetic disease and we expect there to be a family history, we do have new cases that arise. We call that de novo cases or mutations where we may not have a family history. We know this disease will cause the development and expansion of kidney cysts, and it takes a kidney, which is usually the size of your fist, to become quite large in many cases. And these cysts will develop in both kidneys for most people. It increases the weight and the size of the kidneys, and these cysts can range from being very small, the size of a pinhead or a grape, and it can get to be quite large, the size of a grapefruit or a small melon. So there's quite a variability in how these cysts develop. It's interesting because a lot of people, especially in those de novo cases, may not know they have PKD until much later in life. And certainly there are symptoms that can prompt us to investigate for PKD. High blood pressure is a very common one. It can start early, even in adolescence. Or people can have blood in their urine. They can get pain related to cysts that might rupture or expand and push on internal organs. People can get infections within the cyst or develop urine infections, and people can also be more prone to kidney stones. So some of these symptoms, especially even a family which has PKD, might be an important prompt to seek some attention and make a diagnosis. But unfortunately, in many cases, people may not know they have it, and they may not develop these symptoms, and so we do have to screen or investigate in people who may be at high risk. It's interesting, the name is polycystic kidney disease, but actually it affects more than the kidneys, and we'll be talking a bit more about that indirectly. But the common organs that it can also affect are liver. People can get liver cysts, the brain, in terms of the risk of aneurysms. It's fortunately rare, but it's a very important manifestation that we have to be aware of. But there have been reports of heart valve problems, intestinal problems like hernias, and cysts in other organs, including the pancreas and the ovaries and seminal vesicles. So these are all things that can happen that go beyond the scope of just the kidneys. It's important to also note that not everybody gets all these manifestations, and so we sometimes see people with cysts just in some parts of their organs or some organs, and not all of the features that I just talked about. Just to highlight, because it does come back into our conversation a bit, is what do we mean by a genetic disease like ADPKD? The AD stands for autosomal dominant. It really implies that there's a 50-50 chance of a parent passing it on to their child. So here we have a little cartoon of a parent who has the disease PKD, and you can see there's two chromosomes that they harbor. One that mutated or to have the mutated gene, the chromosome that's affected, and the green implies a normal copy of that gene on the other chromosome, and the other parent has two normal genes and chromosomes as represented by the green. And so when we say it's autosomal dominant, it means that there's a 50-50 chance that any of the children can get one of the orange copies versus the green copy. And so as an example, if this couple had 4 children, you would expect 2 of the kids to get the orange chromosome, the mutated gene, and 2 to get the parents' normal gene, the green. Now, this is a probability, and so it doesn't mean that if you have 4 kids, only 2 will have it. It's like flipping a coin. So we can sometimes flip a coin 4 times and see 3 heads and 1 tails, or we can flip it 4 times and rarely see 4 heads and no tails. So it is a probability, and we certainly have examples of families where, unfortunately, the majority of the people are infected, and in other families that no children were affected. So it really is unknown because there is a randomness to it. We'll be talking a bit more about pregnancy care, but I just wanted to highlight a few things that we always want people to be aware of with just maintaining healthy lifestyle and avoiding things that we know can damage the kidneys. So we do encourage people to maintain a healthy diet and body weight. There's no special diet that I recommend in most people. It's really a heart healthy lifestyle and diet. But we do know there's a relationship between obesity and the development of worsening kidney disease. So it is important to focus on that. Exercising regularly, moving. There's no specific activity, perhaps avoiding kickboxing or things that will cause trauma to the kidney area might be something to avoid, however. Obviously, smoking is bad. Really excessive caffeine intake. People can drink a coffee or 2 or 3 a day, but the studies really show very, very extreme amounts to be problematic. Drinking a lot of water is very important. Again, we can talk about that separately. And avoiding things that can be hard on the kidneys, like anti-inflammatory pills. We're talking about things like Motrin and Advil and ibuprofen and Aleve and those kind of medications. And then there's a lot of attention on blood pressure. Won't be the focus of today's discussion, but we do want people to have a good blood pressure target if they have high blood pressure. And we know that there is a treatment that is available. It's called tolvaptan, and it works to effectively, it's not a cure, but it slows the growth of kidney cysts. So there's a hormone called vasopressin, which promotes the growth of kidney cysts, and the medication tolvaptan can block that hormone vasopressin, so it can protect the kidneys from enlarging and hopefully slow down and delay the damage that those cysts can cause. And we have seen some good benefits from people who are at high risk to be on a treatment that can hopefully delay the onset of kidney failure. It does have its side effects, and by blocking this hormone vasopressin, it does make people pee a lot of liquid or fluid, and so it is an important thing that people have to drink a lot of water on this medication, and we also have to monitor for other things like liver enzymes. So I'm gonna that was kind of an overview, but I wanted to I was reflecting on the patients that I follow, and this is Louise. Louise is actually an AI generated image, but it reflects a person in my clinic who's a 27-year-old, and she was diagnosed at the age of 15 because her father had PKD. She has very large kidneys and also has liver cysts. It's not the main problem for her, but she has multiple liver cysts. She actually had a pregnancy 3 years ago, where after the pregnancy, she was known to have high blood pressure, which was treated just transiently. Now, her blood pressure is very good at 123/70H without any medications. And over the last couple of years, she's been taking that medication, tolvaptan. But she'd like to have another baby, and she's sort of asking, what she should consider and what I can tell her. And so it's important also to recognize that there is a large community around PKD. This comes from the international guidelines, what's called the KDIGO guidelines, that a lot of the nephrology community follows, where they looked at the pregnancy in particular. There's a chapter related to that. And as I walk through one of these figures, which talks about the preconception counseling, they highlight the need for genetic counseling on reproductive options. They refer to an expert center, and it's interesting to think about our landscape and in Canada what an expert center might mean. I certainly have a PKD clinic, and we get a lot of referrals, but for pregnancy, my expert center usually falls to Dr. Podymow, who'll be speaking next. And so it is important to have a multidisciplinary approach. And so, Dr. Podymow falls into the nephrologist category with a focus on obstetrical medicine. I will focus on the PKD medicine, and so we will often work together. We do actually have at our site a genetic counselor and a medical geneticist. We have Dr. Thomas Kitzler, as well as Felicia Russo, who have a strong interest in renal genetics. And then we have our obstetrical team as well, although people can be followed elsewhere. So I just highlight sort of how we can reflect on this type of pathway. And with that, I'm going to stop sharing here and allow my colleague, Dr. Podymow, to take over.
That was my wonderful and very cherished colleague, Dr. Ahsan, and we do work very closely together and share a lot of patients. And so thank you again to the PKD Foundation for inviting me to participate in this talk today. And it's true, I did do extra training in specifically in after my kidney training and after my nephrology training, I did do 2 years of extra training in obstetric nephrology at New York Presbyterian with Phyllis August. And so over the years, Dr. Alam and I have shared a good number of patients actually who have been cared for in Dr. Alam's specialty clinic for polycystic kidney disease. And then we co-follow the patients during their pregnancy. And so the objectives I'm going to have today sort of are to introduce the possible risks to the patient, to the woman in having polycystic kidney disease and undertaking a pregnancy, and kind of some things about what to expect with regards to monitoring her health and her baby's health throughout the pregnancy. I'll touch on tolvaptan and as well sort of discuss what entails the sort of follow-up of the woman during the pregnancy. Okay. Sorry. So I'm going to start with this case. And this is a fictitious case, which sort of mirrors Dr. Alam's case. A 30-year-old woman who has been thinking about undertaking pregnancy, and she comes to my clinic to discuss family planning and starting a family. She hasn't been pregnant before. And so she found out about her history of polycystic kidney disease through her mother's own family being affected by it. And her mother had undergone transplant at age 56 with no history of cerebral aneurysm. And the patient herself is really well. I mean, she might not have even known about having polycystic kidney disease had she not undergone screening after her mother was identified as having the disease, and she has it and her sister doesn't. And as mentioned, it's sort of a 50-50 as to whether the gene will be passed on from parent to child. She's healthy. She's got high blood pressure, which is treated with perindopril, an ACE inhibitor. She has no urinary abnormalities. She's had her kidney volume assessed, and she's not on tolvaptan, actually, no liver cysts, and she had no real history of cyst rupture or any kind of infections. And so her questions very reasonably are, will she get pregnant right away? And then what are the risks of a pregnancy to her health? What's going to happen with her blood pressure? Are there any medications that she should be taking during pregnancy or not taking to help her have a healthy pregnancy? And how will the baby be? Will the baby be okay? Will the baby be premature? And then the risks of polycystic kidney disease to the baby. And so those are sort of some very, very standard, reasonable questions, and I'll touch on those. Fertility is not thought to be affected by polycystic kidney disease in either sex, but for sure not in the woman. And so she can expect to conceive, sort of with this similar to the general population. In obstetric medicine, with regards to the pregnancy with any disease that a woman has prior to pregnancy, there's always sort of three main considerations. What are the risks of that disease or condition to the mother's health? And particularly with polycystic kidney disease, what's the risk of her potential risk of kidney function decline during the pregnancy? What's going to happen with the high blood pressure? Is it going to be better or worse? What's going to happen to the liver cysts if they're present? Is there likely to be renal cyst rupture, infection, and aneurysm, as Dr. Alam mentioned, are quite the common manifestations with polycystic kidney disease. And then what are the obstetric risks? So what are specific risks to do with the pregnancy that could be a complication? And the main one that we're usually considering is a condition called preeclampsia, which I'll explain. And then what are the risks to the baby? Will the baby be born prematurely or at term? Are the risks for the baby to be small, and so forth? And so preconception counseling is usually the time where I meet most of my patients when they're considering having a baby. And so the pink slides are kind of all going to be with regards to the preconception issues. Tolvaptan, really, I looked hard and I could not find any human data at all. The animal data shows harm to the developing animal fetus, some bone malformations and cleft palate. And women that are taking tolvaptan are counseled to use contraception to not fall pregnant while they're on the medication. And per the KDIGO, as Dr. Alam mentioned, there's just been a big worldwide guideline with regards to all the different kinds of ways to manage polycystic kidney disease, but as well with regards to pregnancy. And then it's recommended by KDIGO to stop the drug at the time of planning for a pregnancy. Other sources like KI reports say that tolvaptan could in fact be stopped when the pregnancy is diagnosed, when there's a positive pregnancy test. But generally, the drug is stopped at the time of planning for a pregnancy. The risks of the pregnancy on kidney function: if the woman's creatinine is normal prior to conception, before becoming pregnant, the risks that the pregnancy poses to her kidneys is in fact very low. And so if this case, this lady that we're talking about, who has a creatinine of 65 before conception, the chances that she's going to have a normal renal function throughout the pregnancy and after delivery are very good. When someone has kidney dysfunction, chronic kidney disease prior to conception, it's a different story, unfortunately. There's a much higher risk that the pregnancy will cause the kidney function to be lost during the pregnancy. And the creatinine may rise throughout the pregnancy and then remain at that level after the baby is born. And in fact, if the creatinine is very high, like 180, for example, there's even a high chance of the woman needing dialysis during the pregnancy or shortly after delivery. And so that's a very different kind of pregnancy. It's considered very high risk. Most women, though, come to pregnancy with polycystic kidney disease with a fairly normal creatinine. Chronic high blood pressure is a very common issue with women who have polycystic kidney disease. And progesterone is really considered the hormone of pregnancy, and it has a blood pressure lowering effect. And so what happens often is that a woman will become pregnant and the blood pressure will lower naturally, and she'll be able to come off of her blood pressure medications after conception. This happens very early in pregnancy. By 8 or 9 weeks, the blood pressure is already low, and it might be even the first symptom of pregnancy for women that weren't really planning a pregnancy, that they feel lightheaded because the blood pressure really does go much lower. And so there's that. And then the other issue is that some antihypertensives, such as ACE inhibitors and angiotensin receptor blockers, are not good for the developing fetus in the 2nd and 3rd trimesters. And so perindopril is what the patient in this case, this story was taking prior to conception. And so once she would have a positive pregnancy test, she would be instructed to then stop the perindopril with a positive pregnancy test and to monitor her blood pressure, because as noted, the pressure might just naturally stay low even without the medication. And if she needed blood pressure medication during the pregnancy in the 2nd and 3rd trimesters, or really any time during the pregnancy, the medications known to be safe in pregnancy, like methyldopa, labetalol, and nifedipine, are very commonly used in pregnancy, and there's good safety data that the babies develop normally. And these are also good medications to use in breastfeeding as well. They're safe both for pregnancy and breastfeeding. And the target blood pressure in any kind of kidney disease is considered, we try for a normal blood pressure during pregnancy, and prescribe the medications to attain that level. Urinary infections may be more common in women who have polycystic kidney disease. And so frequently in pregnancy, surveillance urine cultures are done. These are done for women that don't have any symptoms at all, but the cultures are done on a monthly basis to try and catch any positive cultures. The reason being that women who have a urine culture that's positive, even if they don't have any symptoms, is associated with preterm labor. And so those women are all treated for any kind of positive urine culture. And the antibiotics that are used are safe, are known to be safe in pregnancy. And if a woman is known to have many urine infections, then she may be started on an antibiotic throughout the pregnancy, sort of a suppressive antibiotic and a low dose for the pregnancy to protect her against urine infections. Cerebral aneurysms are a very uncommon issue in pregnancy, but we do know that the frequency in polycystic kidney disease patients is higher. So usually aneurysm screening will be done. Frequently, it's advised to have aneurysm screening prior to natural labor, but even in the presence of aneurysms, the obstetric population, the obstetricians usually don't consider having a small aneurysm as a contraindication to a natural vaginal delivery. And so usually a CT scan is done or an MRI is done, and both of those, if they need to be done during pregnancy, can be done safely. The CT could be done with a contrast or coloring. The MRI is done without, but those are considered safe tests to be done in pregnancy if needed. And really, if there really was a large aneurysm, that patient would be referred to neurosurgery, and there's ways to safely deal with aneurysms if they need to be treated or managed prior to pregnancy or even during. With regards to the cystic kidneys and cystic livers, cyst ruptures really don't occur more commonly with pregnancy, but if they do occur, they're managed with pain control, and acetaminophen is considered safe during all trimesters of pregnancy, and there's other medications that are safe as well. Non-steroidal anti-inflammatories are not really safe in pregnancy. They're associated with problems with the developing baby heart, and so we usually don't use Advil or Motrin during the pregnancy. Liver cysts are common, and they're more common perhaps in women because of estrogen. That being said, there's really no reports of any pregnancy-associated complications with polycystic liver disease. And recently out of New York, a study was shown that women who have pregnancy do have slightly more progression of their liver cysts, but what that really means in the long term is not known. Pregnancy is a short time in life, it's only 9 months. And so those authors sort of said, yes, pregnancy might cause there to be more polycystic liver disease, but what that really means, it might not mean anything at all. So we really don't know the answer to that question quite yet. So what's going to happen then in the pregnancy? And we're really now talking about that issue of preeclampsia. And probably by now, many women will have heard of preeclampsia. It's very common in the whole population, normal population. Preeclampsia develops in 5% of all pregnancies. And so by kind of the age where people start having kids, you start hearing about a family member or a friend who's had preeclampsia. And what it is a condition that develops in the second half of pregnancy that is associated with new high blood pressure, some swelling and sudden weight gain, and perhaps headache, and as well the urine protein is elevated. And the issue with preeclampsia, the problem with it, usually the mother does fine and the baby does fine, and especially if preeclampsia develops at term. But the issue really is when preeclampsia develops a little bit more early, preterm, sort of in the 32, 34 week area, if the blood pressure becomes very difficult to control, or the baby's blood supply from the placenta is not good, it sometimes forces the hand of the obstetrician to have to deliver the baby early. And preeclampsia is in fact the #1 cause of indicated prematurity, where the obstetrician is delivering the baby early for the sake of the safety of the baby and for the safety of the mother as well. And so preeclampsia occurs quite commonly. Mostly it's term preeclampsia, but it can be earlier than that. And the question that women with polycystic kidney disease may ask is my risk of preeclampsia increased? And the risk really depends on the mothers. There are different risk factors that make preeclampsia more common than in the general population. If the creatinine is normal, if blood pressure is normal and there's no urine protein, the risk isn't any more elevated than in the general population. But if there is some renal dysfunction, so if pre-pregnancy the creatinine is elevated, if there's already protein in the urine, or if the woman already has high blood pressure, medicated high blood pressure, the risk of developing preeclampsia in pregnancy is higher than the general population. It's thought to be 20 to 30%. And to prevent preeclampsia from occurring, we prescribe baby aspirin, 2 baby aspirins taken at bedtime, started early in pregnancy, helps the placenta develop better. And that is what ends up preventing preeclampsia. It lowers the risk by about 10%. And the woman is also advised to monitor her own blood pressure at home and to have a home blood pressure cuff and to take the blood pressures on a daily basis, because really the women are only seen by doctors maybe once a week, but they can monitor their blood pressure every day and know what the symptoms are and trust themselves. Usually the woman will diagnose preeclampsia in herself and present to labor and delivery and say, listen, my blood pressure's been above my target, or I have a headache, or I have new swelling that's really developed almost overnight. And the woman will be admitted to hospital. Blood pressure will be treated. They'll check the status of the baby, and the obstetrical team and the maternal fetal medicine team will all decide, okay, things are stable, we can continue with the pregnancy, or, for one reason or another, we know sort of what the condition of the mother and the baby are and whether the blood pressure is easy to control. But for the most part, even if a woman develops preeclampsia, usually there's time to lower the blood pressure and to make all of the assessments to make sure everybody is safe in the pregnancy. So what a woman can expect, a woman with polycystic kidney disease can expect during pregnancy is regular monitoring of blood pressure. And then if the blood pressure is elevated above target, the woman would be started on antihypertensive safe in pregnancy. The woman can expect to have blood tests perhaps more frequent than the general population, monitoring both the kidney function and as well as the labs to check for preeclampsia blood tests in the blood. And then urine screening for urine protein, which is another sign of preeclampsia, as well as sort of surveillance screening urine cultures. What are the risks to the baby? So we've already talked about the risks of preeclampsia that may be elevated in women who have some chronic kidney insufficiency or high blood pressure. And so the risks to the baby are mostly related to that, to prematurity. In women who do have renal dysfunction, there could be a lower birth weight, and the baby has a higher chance of being admitted to a neonatal intensive care unit. And then, as we noted, the risk of transmitting autosomal dominant polycystic kidney disease gene from parent to baby is 50%. And so the risk of inheriting the gene is there. And for children from the pediatric side, they're sort of monitored. Usually it's not a disease of childhood, but children are monitored from an early age for blood pressure, and depending, may be monitored for other issues as well. Postpartum, breastfeeding is safe with all of the blood pressure medications that would have been started in pregnancy. And if the woman sort of responds well to an ACE inhibitor in breastfeeding, enalapril has been found safe by the American Pediatric Association guidelines. It's probably a class effect. Probably all the ACE inhibitors are safe, but that is the one that we use because it's already been tested in breast milk of mothers to see that the transmission to the actual infant is very low. Tolvaptan may be excreted into breast milk. So at this time, the use of tolvaptan tolvaptan is not prescribed while the mother is breastfeeding and would only be re-prescribed after she has finished weaning the infant. With regards to contraception, because of the risk of estrogen having an effect on cysts, particularly liver cysts, progesterone-only methods are favored, and the amount of progesterone or any hormone in the IUD is quite a bit lower than the amount of hormones that are found in oral contraception. And so IUD is commonly prescribed for women. For those that are finished having their families, they've had as many children as they want. We always say that the safest birth control for a woman is a vasectomy for the man. And so I will just sort of leave that there. But at any rate, IUD is found to be safe. And then if women do develop preeclampsia, it is a risk factor for heart disease and stroke in later life. And so a woman in her 30s that might have, or 20s that might have preeclampsia in later life would be monitored for high blood pressure and cholesterol and diabetes monitoring and so on in later life to try and make sure that these issues are watched for and treated if they do develop. can transmission of the polycystic kidney disease gene be controlled? And so this is just a quick kind of just to touch on this topic. And so there is a way to do in vitro fertilization and something called pre-implantation genetic diagnosis. So what is that? So we know that the baby has a 50% chance of getting the gene passed from the mother to the embryo. And so what this is in vitro fertilization, where the eggs are sort of taken here. This is they're sort of taken from they go through the vagina, they get the eggs and they take them out. And it's sort of just not a terribly invasive procedure. It's very commonly done. Thousands and thousands of women have had in vitro fertilization, and then they make the embryos with the sperm, and then they take a look at all of the embryos, and they take 1 or 2 cells from each of the embryos, and with that one cell, they take 1 cell and they do the genetics of that 1 cell, and that tells you whether the whole embryo is affected has the polycystic gene or not. And it's 50-50, right? So you'd expect around 50% of the embryos created to have polycystic kidney disease gene. And so what this does is effectively choose only the embryos that don't have the polycystic kidney disease gene and transfer only those embryos back to the woman so that she's guaranteed to have a baby that's not affected by polycystic kidney disease. There is a geneticist that does this at McGill, Dr. Ahsan, and it's something that I haven't seen done super commonly for polycystic kidney disease, although there are women who have a history where they would like to have that done. Of course, there's the cost to IVF, and undergoing IVF isn't a relaxing experience necessarily. There's also equity with regards to whether everyone can afford such a thing, ethical concerns of what to do with the embryos that are discarded, etc. And so I just wanted to touch upon the fact that it is in fact possible to do this genetic testing. There's also the idea of having egg donors for a woman who has a family, has the history of polycystic kidney disease, or sperm donors if it's her partner who has the family history and personal history of polycystic kidney disease. So those are some different ways that people can go about having children who are not affected with polycystic kidney disease. Just a touch on it of how that works. And so this is our lady here with who comes for preconception counseling, and she was on perindopril, and so had the questions as we sort of touched upon at the beginning. And she gets pregnant and naturally conceives and stops her perindopril with the positive pregnancy test. And even without the perindopril, her blood pressure remains normal or even low. She started on aspirin. 2 baby aspirins are started at 6 weeks gestation as prevention for preeclampsia. Because of her high blood pressure, she's at increased risk at about 25% chance of getting preeclampsia. And the aspirin lowers that risk to about 15%. So it's quite a good method of lowering the chance of having preeclampsia. She's then followed by obstetrics, high risk obstetrics. Usually she's co-followed by obstetric medicine or obstetric nephrology in my case. She gets the usual screening ultrasounds. The baby is doing well. Her blood pressure remains low. And then around, sort of it starts to creep up to its pre-unmedicated level. And so labetalol is started at the 26th week. And that's quite typical, actually. As the pregnancy goes on, the blood pressure does tend to creep up to its unmedicated levels. And usually a woman needs to be started on something. So the choice of medication safe in pregnancy is an easy one. She has monthly surveillance urine cultures that remain negative. And she sails through her pregnancy. She does well. She goes into labor and she delivers a healthy baby at 38 weeks. And I should have mentioned that prior to all of this, she had not been screened for a cerebral aneurysm. And so a screening CT was done somewhere in the beginning of the pregnancy, and she did not have any findings of that. And so this is sort of commonly what a woman with polycystic kidney disease, the patients usually do well. If the blood pressure is easy to control and the kidney function is normal prior to pregnancy, usually people do quite well. And so thank you very much again for inviting me and Dr. Alam. And I just wanted to know if there's any questions for either of us today. So I'll stop my share.
Thank you so much to both of you. That was a really informative presentation. And I know there are some live viewers on the call. If you have any questions for either doctor, please feel free to put them in the chat or in the Q&A area. I'm going to start with some questions that I often hear from people who are contacting us about the whole issue of getting pregnant or starting a family. What if a woman is older and her PKD has progressed, say, to maybe stage 3? Does that then involve some conversations about whether it's even wise to conceive? And what kind of considerations does her healthcare team want to think about before she becomes pregnant?
Yeah, for sure. I mean, the general with any cause of the kidney disease prior to pregnancy, if there's renal dysfunction, then the risk very much goes up with pregnancy. And so the general rule from the studies that are sort of now have been around for 30 years and the new ones that are coming out, if the creatinine is less than 120, say, usually the risk is low and the woman can go ahead and get pregnant. And there's still a small risk that kidney function will worsen during pregnancy. There's quite a bigger risk for preeclampsia and blood pressure issues. But for the most part, we give the green light. If the creatinine is in the 140s, 150s, there's a 1/3 chance that during the pregnancy, the creatinine will get worse and remain elevated after the baby's born. So quite a big risk of sort of an accelerated kidney disease worsening. Why this happens, we don't know. We know that there's extra burden put on the kidneys during pregnancy. They act as filters and they clean the blood, and the filtering is much increased during pregnancy. It might have something to do with that. We still don't really know. If the creatinine is 160 or above, the risk is very elevated at that point, that the woman's kidney function will get worse. And in fact, in the studies, about 1/3 of women who have high creatinine before conception end up on dialysis either during the pregnancy or very soon after. So it is a very high risk sort of consideration. And it's a hard one, we didn't really touch upon transplant, but after a successful transplant, many women go on to have a baby after kidney transplant. And so that's one thing to consider, but it's it's the hardest part of my job is telling women, like, look, your risks are very, you have a very serious situation here and your risks are very high because the wish to have a family can be very big. Some women have, there's many ways to hold a baby, which is nice. And I have known women that have had, surrogacy and there's different ways, but it's a very fraught, very difficult decision, I would say, Fortunately, most of the women have good kidney function, even with polycystic kidney disease. It's a disease that sort of, it progresses in the 50s and 60s more than it does in the 20s and 30s, but it is chronic kidney disease is a very, very high risk pregnancy for sure.
I know one of our community members who regularly shares advocacy and information about her own PKD journey on social media has recently talked about how she already has two healthy children and but really still kind of has that urge that her family is not finished yet. And she said when she went to her nephrologist, he was like, you know, this would be a very different conversation if you didn't already have children, but in your mid 30s, you've had children, you know. So it was really interesting to see her perspective and see her kind of grapple with what that meant.
Yeah,
And
it's
I
true. The pregnancy can really badly affect a woman's health. And it is a reality that I wish was not true, but it is.
Um, there are a couple of questions that have shown up in the chat. Someone is asking, what are some postpartum complications that could be expected for a patient with PKD or PLD? Would there be an extended hospitalization or anything like that?
I think it's, it sort of depends on the same, how's the kidney function, how's the blood pressure, is the blood pressure easy to control? Did the woman develop any complications either related to kidney disease or not? But is preeclampsia part of the picture? Is the blood pressure easy to control after delivery? For most women, people do well. They don't have too many issues with regards to blood pressure or postpartum. They sort of, if they have preeclampsia, that does tack on some time to the hospital stay. If there's a cesarean section with or without, kidney disease, that might add some time to the hospital stay by a day or two, so it's very variable, but specifically due to the polycystic kidney disease, given, if the blood pressure is normal and the creatinine is normal, no, it shouldn't. I have not seen that with my patients, no.
Great. And I would say to the person who has asked that question, if there's anything in particular that you might be concerned about or something related to your own condition that you might want to know about, feel free to ask another question. Someone else is asking, I know this woman is a potential grandmother down the road, but she's asking if the male partner has PKD, does that in any way affect the pregnancy of the person who's not got PKD but carrying the baby?
It should not.
That's great. For you mentioned briefly dialysis during pregnancy as sometimes necessary for an emergent issue. If someone is already on dialysis, I'm assuming that it might they might be counseled to try and avoid pregnancy if possible. Like, is it something that happens where someone on dialysis gets pregnant and carries a child?
Yeah, pregnancy dialysis, women who are on dialysis and become pregnant, it's a very big project for them. They need to undergo daily dialysis and often are hospitalized for the latter third of the pregnancy. It's not a relaxing experience for women, and there's a lot of risks of, preeclampsia of a small baby, premature baby, and so forth. And about every 2 to 3 years, we do manage someone who's become pregnant on dialysis. It's usually advised not to become pregnant on dialysis because it's such a risk to a mother's health and to the baby's health. But it happens, when we manage these women very carefully.
Understood.
Yeah, I
And you
might
also
add,
talked
I
go
just might
ahead.
add, often when we see people with advanced kidney disease, severe kidney disease on dialysis, they often aren't having the same level of fertility. They're not menstruating in the same way, which is interesting when they get their kidney transplant, because then we do have to resume that conversation about contraception, because their periods start again and they become fertile, and can have a pregnancy again. So there's a transition in terms of their ability to get pregnant.
Can we talk a little bit more about pregnancy, conception and pregnancy after transplant. Are there things that, as a nephrologist, you're interested in monitoring with the patient, and any potential risks that come along with having had a transplant, and obviously on quite a lot of anti-rejection medication with trying to conceive or carry a child?
Maybe
Yes.
I'll just start by saying, again, I think as Dr. Podymow mentioned, most people with PKD, fortunately, well, and hopefully, will only develop kidney failure down the road in their fifth, sixth, seventh decade of life. There are cases where we do have people who develop, the need for dialysis much earlier. So, but in general, it is an important subject. And, my view is that transplantation is a way for people to get back to a more normal life. And so we do want to, have people get a transplant so they can return to a life. And a lot of people who were not able to conceive on dialysis are hopeful when they get a transplant that they can have a baby. And we do encourage it. It's just the timing is important to consider. Maybe I'll let Dr. Podymow talk a little bit about what she counsels people.
Yeah, exactly. So after the transplant, because the immunosuppression needs in the early post-transplant period, and they're much higher infection risks, we usually counsel women to use contraception for at least 1 and ideally 2 years after having a kidney transplant, so that the patient is on a stable dose of immunosuppression, the kidney function is stable, and we want the kidney function to be as good as possible as well, just like everybody else, to have as normal as possible kidney function before conception, to have the best sort of health in supporting a pregnancy. And so that's sort of a big sort of what the big part of the counseling is, because after transplant, the fertility can return within a few months. The kidney failure causes a disruption of the pituitary ovarian axis. And so a lot of women that are on dialysis don't ovulate at all. They stop having their periods. And then after transplant, you sort of have to really be sure that, a contraception plan is really in place, so that it's a very controlled sort of a plan, and as safe as possible. And then when they do have babies after transplant, we're thrilled. It's great.
Yeah. And there's an issue with medications. There are some medications that probably women should not be on, and so we make a plan to switch them when we are aware that they're going to be pregnant, including the blood pressure pill that Dr. Podymow talked about. That class of medications will modify. But again, we are happy to involve Dr. Podymow for our transplant patients as well. We're very fortunate to have a medical obstetrics expert on our team.
Awesome. And I know another member of our community who, again, is very active on social media and sharing her story, is post-transplant, is fairly young, and is trying to conceive via IVF with the pre-implantation genetic testing. And that becomes a whole thing in itself, because when she waited the healthy period after her transplant, that then pushed her into an older age to be conceiving, and obviously they're doing it through IVF, but multiple issues to deal with then. I have one more question. One thing we often hear from patients who are nearing kidney failure and thinking about transplant, or already on the transplant list, or looking for a living donor, they discover that they're highly sensitized, and often it's because they've had multiple pregnancies when they were younger. Is this something that ever enters into the conversation with a patient who has not yet had a child but is interested in having natural children? Is it ever brought up that it may down the road lead them to have more antibodies against a lot of different blood, other organs?
Ahsan, maybe you want to take that one.
Yeah, it's a very interesting question, and it's a very difficult one, I think, because people put different values on different sort of outcomes. Is having a baby with the more or less important versus the potential for needing a transplant down the road. What are the opportunities for transplantation. You know, and I think it's a very interesting question. Even the idea of pregnancy, not everybody gets sensitized, even with a pregnancy, and so it's not easy to guarantee or predict, you know, an outcome of a pregnancy. But just for people who are not aware, you know, we do check for what's antibodies against what are called HLA genes. So, you know, antibodies that could be in the blood that would recognize something foreign, another person's organ. And the more antibodies you have, the harder it could be to find a match. We can mitigate a little bit of that problem because there are ways to be involved in, say, pair donation programs. Obviously, hopefully we can mobilize more living donors who we can find the right match. And then, of course, you could be on a waiting list for a deceased kidney, which, you know, comes from a person that is a match. And so there are options. And so to weigh that risk against the immediate sort of concern about getting pregnant and having a family and starting a family at the right time is a tough one. I don't get into those sort of discussions because it's very hard to inform people. Well, I think it's a great point you bring up, but it's a hypothetical kind of challenge to lay out. I don't know if Dr. Podymow has another perspective.
No, absolutely. You don't really know. There's women who have had lots of children and that go on to have a transplant without an issue. And so it's really, you know, we're trying to understand tolerance and sensitization and all those different things. And it's an ongoing story, I think, but it's hard to really know.
Yeah.
Thank you both so much for your answers to the questions. And I see we're a little bit over time right now, so I will wrap up. Just want to thank both of you for being here today, for taking the time and talking with us about this particular topic. It's one that we get asked quite a lot at the foundation. People will be emailing us or calling us, and it's really great to be able to have a resource that we can then direct them to, that we trust. So thank you both. I'll say to everyone who's still on the call that we are recording this session and it will be available on our YouTube channel in the coming weeks, and everyone who has registered will get an email letting them know. And if you have any additional questions you'd like us to ask the doctors here, or any other questions in general, you can always email us at endpkd@endpkd.ca. Thank you so much, everyone.